Henry.
Oh yeah, I can find you.
Hi, how are you, bro? First of all, I would like to thank you, Henry, for this kind of opportunity for both of our residents to both of our side. I mean, we had that planned since I guess 2019 when we signed our MOU. Of course, we go back way back, Professor Henry and I, but. We were hoping in December 2019 to start and initiate this process, but no one knew what would had happened at that time. So I'm very happy to see that we are back on the track. Hopefully, this is a small step, just a start, and soon we will be more active in the progress of cooperation between our universities, inshallah. So
Sure.
thank you very much, Professor Henry, for the chance. And I guess I know you are very strict on time, so we will, if you don't mind, we will start with
Rashid,
now.
if you don't mind, I just want to take a picture of everyone, just saying hello.
Hello, but can you ask your colleagues to open the video? So
Yeah,
many of
we
your
can.
colleagues close the video in the screen. So
Sure.
if they can start the video.
Yeah.
Rashid, تفضل Rashid, if you can ask our student to open
Yeah,
their
can
video.
you please, our team to, who can, of course, if you are in a place where you can open up your camera, do it so we can take a picture. Or at least be prepared, because at the end we will take another one. If you,
Oh,
I
sure.
think
Yeah,
it
yeah.
might be a
Maybe
good idea.
later on we can take another screenshot.
Yeah, let's do that.
Okay, so let me introduce myself first, because many of your colleagues does not know me, right? So
Yeah,
of course,
well,
many of
we always
my
mention your name.
yeah, you know me very well, but many of my
No,
students does
and
not
your
recognize
name is very common in my faculty. I mean, we have the
really.
NDC device, which is yours. So
Really
it's
good to know
there,
that.
yeah. We cannot forget about you,
Good to know
Henry.
that, yeah. As Rashid said, many of my international friends call me Henry, but my official name is Hyunchul Kim, and all articles are with my official name, with Hyunchul Kim. I don't know when it was, but many times ago, long time ago, Rashid talked about the one article from mine, but at that time he didn't recognize that is my article, because Rashid knows me as only Henry Kim. So that's very funny situation at that time. So as Rashid said, we have the MOU last year, maybe 2 years before. I don't know. Is that?
December, we signed it in Cairo, Henry, if you remember, the official signature,
Yeah, yeah.
because we had one just for the science, but then we had a more comprehensive one. We signed it in December 2019 during the
19,
PAN
yeah,
Endo
yeah.
conference.
Okay, yeah. So that is 2 years before. So
Yeah,
anyway, so
December,
after
by the
we
way.
have the COVID situation, so we cannot make any chance to see each other, and even we cannot meet in the scientific field. So today we try to have the joint seminar, and not very difficult one. I mean, the scientific one is sometimes boring and difficult. So this time we just wanted to start with clinical seminar that is much easier than the academic ones. So hopefully all of your colleagues, your students, and my students may feel fun. I wish they feel fun from this, my school, because they are quite nervous about to speak English. So I wish they can enjoy this time, and we will have much more chance to exchange our experience and our culture at school, and we may find what is different from each other, each institution. So if any of
If
you
I
want
may
to
add,
say greeting,
Henry, I just wanted to add something that to your residents and to mine, since we have the chance to talk. Guys, personal kind of contact, it is very important when it comes to your future. I mean, there is, for me personally, knowing Henry, and actually didn't know that it was him when I first met him, helped me a lot in developing my career further and open up my eyes into that. So I hope one of the things you should consider when we do these courses, that my aim, and I'm sure Professor Hyunchul's aim, is to put you all together to start integrating the school. So don't feel shy about the language, or English is not our first language, by the way. So don't feel irritated. And we hope for my residents and Hyunchul residents that these chances will help you in your future development. That's why we want to start with this. And hopefully this is just and only the start, and more, inshallah, in the future will be happening.
Okay, great. Then let us try to introduce ourselves one by one, just name, with some more information if they want. Is that okay?
Yeah, go ahead.
So, yeah, we can start from our side, from Busan. So Yari, can you start your introduction by yourself and then all the resident one by one? Just your name and whatever you want to say.
Okay. Hello, everyone. My name is Yari Park, and I'm a second-year resident of Dental Hospital of Busan Regional University, and I'll be performing today. And I'm so glad to meet all of you here. Thank you.
Next.
Same here.
Next, Gina.
Hello. Hello, my name is Yu Kang. Thank you.
So each one of you guys.
Can you raise your hand who introduce yourself?
Yeah, because we cannot see the mask.
Oh, yeah.
Okay.
They are all gathering together at the
Okay.
And next, how about Gina, Dr. Gu?
Hello, my name is Gina Ku.
Raise your hand.
Hi, my name is Gina Ku. Nice to meet you. Thank you.
Nice meeting you.
And then next, Jihan.
Hi, my name is Jihyun Lee. I'm so nervous and nice to meet you. Thank you.
Thank you, dear.
And Youngjun. Nothing to say?
She is muted, maybe.
Hi, my name is Youngjun Kwon. Nice to meet you.
So simple.
Yeah.
And me?
Hello, everyone. My name is Eunmi Kim. Nice to meet you.
Nice to meet you, dear.
Yenny?
Hi, my name is Yenip.
Oh, you turn off your video. So actually we have four more residents, but they are in third grade. Now they are preparing the national board exam. So they are studying in some space. I don't know where they are now, but they didn't join this time. So Yenny is preparing the video. So it's your turn from MBRU, please.
Okay, maybe Fatma, you can start introducing third year first. Your mic is muted, Fatma.
Hi, my name is Fatma Ahmed. I'm a third year endodontic resident in MBRU. Nice to meet you all.
Ahmed.
Hello, everyone. My name is Ahmed El-Jberan. I am third year endodontic resident. I will be the presenter today. Nice to meet you, everyone.
Tariq.
Hi, my name is Tariq Abdul Karim. I am from Kuwait. I am third year resident, and nice to meet you, everyone.
Yasmin.
Hi, everyone. My name is Yasmin. I'm a third year endodontic resident at MBRU. I live in Dubai, and it's a pleasure meeting you all.
course, these are the third-year residents. We have, yeah, just Dr. Amri, I just noticed he joined us. So if you, Dr. Amri is our new faculty. Well, he's already a whole semester with us. If you like to introduce yourself, Dr. Amri.
Hi, everyone. It's a pleasure to meet you. I'm just joined MBRU 3 months ago, but actually it was a great pleasure to meet you all and looking forward for this discussion today.
Welcome to MBRU. Congratulations.
Thank you, Andy. So I guess, should we go ahead because the others, they don't have their camera on. We will, should we start with the presentation?
Yeah, sure.
Yeah, so you like ours or yours? What do you
Yeah,
like?
we'll start first.
Okay,
So,
good.
Today, Dr. Park Ye-ri and Dr. Yu Gang both prepared the presentation. So who will start first? Yeri? Yeri?
Yeah.
Okay, you start first, Yeri.
제가
Oh, Yujang? Oh, okay. Yujang start first.
Okay, good.
이거 안 되는데.
잘 되고 있는데.
아, 네.
아까 되었어. 이거 반대인데. 아까가 됐었는데.
먼저.
제가 먼저 시작하겠습니다. Hello, everyone. My name is Yeri Park, a second-year resident. Today, I want to share one of my cases about revascularization. And for your information, this was my first revascularization that was done last year, so there might be some changes compared to the treatments I do nowadays. I'll start with the patient's information. 11 years old, male patient was referred from local dental clinic. According to his mother, he had pus discharge due to the fracture of dens esophageatus, but I couldn't see any sinus tract. He had no past medical history or past dental history. By clinical examination, I could find fracture of dens esophageatus on number 35, the mandibular left first premolar. The patient had no spontaneous pain, but had a positive response on percussion. This is panoramic view and periapical x-rays. With these radiographic examination, we could see that the teeth of the chief complaint site had incomplete root development and apical lesion. With these clinical and radiographic information, I diagnosed the tooth pulp and apical part as the crown fracture, pulp necrosis, symptomatic apical periodontitis, respectively. Treatment plan was revascularization on number 35. Now the procedures. I used AAE, the American Association of Endodontists, clinical considerations for a regenerative procedure as a reference guide, but there are some differences. On the first day, local anesthesia with the lidocaine was done. After rubber dam application, what it says access opening here, but my patient already had the access open from the local clinic due to the pain to our first appointment. I measured the working length with digital x-ray. This is the procedure I exclude nowadays. Channelization was done with 20 milliliter of 1.5% sodium hypochlorite and saline without any instrumentation. Calcium hydroxide was used as an intracanal medication. Then the cotton and caviton was used for the temporary sealing. A week later, on second appointment, patient had negative response to percussion. Canal irrigation was done once again without instrumentation. Nowadays, since I don't use calcium hydroxide and leave the canal emptied, this process is skipped and it results in less visits for the patient. On third visit, the patient still had negative response to the percussion. So the local anesthesia with 3% methylocaine was done. After rubber dam application, canal was irrigated with a line 10 milliliter of 17% EDTA. I also used the ultrasonic irrigation equipment. Then I dried the canal with a paper point, and by rotating pre-curved number 25H file, bleeding was induced. After waiting for 15 minutes, blood clot was formed and the serum above it was soaked with the paper point. MTA filling was performed with retro MTA. After I put the lead coating, Captain was once again used for the temporary sealing. Finally, on fourth visit, after etching with the Ultra Etch, Edinburgh Scotchblunt multi-purpose adhesive system was applied. Then Luxacor sheet A3 was used for the final restoration. Here are periapical x-rays of the pre-operation, post-operation, 1 month checkup, 3 month checkup, a year checkup, and at last, a 1.5 year checkup. He had no symptoms, and we can see the total length of the root has grown and got thicker. Then that's all for my presentation. Thank you for listening. I would like to ask you what kind of materials you use for the intracanal medication during revascularization, and if there are any things that are different from the standard protocols.
Thank you very much for it. I mean, you will be amazed that we are following the similar kind of format even in the presentation. Once you look at our presentation, I think Muhammad might comment about that. Dr. Muhammad MJ, if you have any commitment regarding the materials of the revascularization, since it's his kind of field of expertise.
I think I will leave it to our students. If any of our students can, anyone, I think Fatma, she did the revascularization case, so she want to describe that more.
Okay, I think it's somehow similar to what we are doing. Even there is like a new different technique that it was experimental studies that going on, like to use a different irrigation technique and if we are using the triple antibiotic or not. But what we are doing in our clinic for now, it's similar to that, the one you are doing. And with consideration to use a type of MTA that it might not cause an discoloration and in the case that we select.
And the medication is calcium hydroxide, Fatma?
Medication is calcium hydroxide.
So, Dr. Fatma, you said you don't use the triple antibiotics for your cases?
Our cases we didn't use, but there is like different recommendations and different like experimental studies that are going on, like in case of persistence infection, they can use a triple antibiotic for that cases. But I don't know, Dr. Mohammed, if you have a comment on that.
Yeah, I think the studies have shown no difference actually between like in vitro studies and some in vivo studies. There is no significant difference between the calcium hydroxide, the triple or the double antibiotic based. And maybe the calcium hydroxide, it's more popular because it's available and it's easy to use. So that's why we always used like the calcium hydroxide. But the question I have here is that how easy was to induce the bleeding in your case? I mean, did you find it to be easy step? Did you struggle with that? Can you share your experience?
Thankfully, it was quite easy for this patient. He had I think it had a bit apical part, so it wasn't that hard for this patient.
And did you use like a matrix below the MTA, like a color coat or a color plug below the MTA as a matrix to condense the MTA over?
No, we didn't use any metrics. So it was quite hard when using the retro MTA to seal to be neat. So nowadays we try to use the product like one fill putty, which is more easy to use. So
Okay.
I think that's the difference between nowadays
Sure.
and back then.
Sure, sure. Thank you. Excellent case. Excellent case.
Thank you, sir.
Agree.
I have one more comments about these procedures. So Dr. Park, as Dr. Park told, we don't use the triple antibiotics in our clinic because it's quite difficult to subscribe the medication to the, especially for the younger patient. So we sometimes use the calcium hydroxide, but for my cases, I actually do not use any that kind of medication because even the calcium hydroxide paste itself has some ingredient like small particles. So it will be quite difficult to make very clean dentinal walls. So that may interfere to the cells are growing at the root dental wall. So that's why I don't use any intracranial medication for this revascularized cases. So I wonder what to think about my idea.
Henry, if I may say one thing also, since we have brought the calcium hydroxide issue a bit, I mean, yeah, it is much user-friendly to use the calcium hydroxide if needed inside the canal, and especially the pre-mix. But I have noticed recently that there is a tendency from the manufacturer, and a good example is Meta, for instance, that they shifted from the oil-based type of calcium hydroxide to a water-based calcium hydroxide. Do you think you might, as a person who is not using calcium hydroxide, change your mind a bit now that you have a water-based calcium in a ready mix, or that wouldn't make a big difference for you?
Even the water-based calcium hydroxide itself has some particles in the paste itself. So after the period of the medication period, we have to remove all that materials from the root canal system. So it's not so simple, quite easy, but we cannot clean perfectly. So I do not recommend to use that paste inside the root canals for this revascularization technique. That is my different idea.
Thank you.
Actually, I think Rashid, yani, if you allow me, I think for the I totally agree with Henry. Like if it will gonna interfere with the bleeding or the attachment of the cells to the dentinal wall, especially like in a molar, if the case is difficult to take the calcium hydroxide from, I totally agree. I think the only purpose of the calcium hydroxide is to allow enough environment for the healing and for a resolution of these high-end symptoms. I still remember that we had a meeting once with Ken Hargraves in one of the regeneration meetings, and there was actually like an advocation to even move to a higher kind of concentration of the triple antibiotic paste, because there are some cases which are actually not easy to overcome the persistent infection. So yes, I guess I agree with Henry. Like if there is a case which is a persistent infection, maybe a need, but if there is no need, I think we can go with without any kind of medication.
Yes.
Can I have a comment? Just.
Yeah, sure. Go ahead.
Yeah, just a question, because I'm not much into revascularization. I haven't done it much, and that would be actually useful to know. Because as far as I know, for calcium hydroxide, it has, other than just its antimicrobial effect, it can actually mediate signaling with cells or induce the release of signaling matrix proteins from dentin. Would that outcome the disadvantage of residual particles left after removing?
I'm not sure about those questions, but the EDTA is actually we have to use to make the conditions for the cell viability for the new cells growing inside at the dental wall. But I'm not sure about the calcium hydroxide that is actually working about that. So anybody who are aware of this from MBRU?
So actually, yes, what Dr. Amr said is very interesting and also true. I think one of the effects of the calcium hydroxide is to release some growth factor from the antenna. So actually, one of the theories why the calcium hydroxide can work as a direct bulb capping agent, it's not only because of the high pH and the necrosis air that it can induce, but I agree with Amr. There are some theories, especially the paper by Tony Smith, in which they clearly shows that the calcium hydroxide can release some growth factor from the antenna, and actually this is why it can induce the secondary or the tertiary antenna.
It's very difficult to accept all the theories, but in my ideas, for our clinical situations, we have to have simple procedure to make the clean results. So that's why I'm not using that calcium hydroxide. But we have to use the EDTA to get the growth factor from the dental walls. That's my idea, and we are following those theories. Okay, we spend.
I mean, overall, Henry, if you don't mind for interruption, because I guess we have to move a bit. Overall, I would believe the outline recommended from the American Association of Endodontics is as our guide, and we want, if I can achieve my disinfection of the root canal system with an irrigation and sodium hypochlorite, I mean, that would be. This will not necessitate to use any kind of medication, whether calcium hydroxide or any of it. And of course, the simpler the procedure is, the easier the more dentists will be motivated to treat and so on. So, good idea. I mean, even there, your colleague, I mean, your student didn't even use a quote and managed to get somewhat of a control of that. So that even simplified the procedure further. And results, I mean, they really, the postoperative X-ray looks really good, and we hope that with time, this will be a routine kind of a practice of procedure for all of us. I know you are strict about time, so would you like to present the second student, and we maybe have more time for the discussion later?
Maybe we can move on to the next cases.
Yeah.
How about from the MBRU this time? One by one?
Your choice. Okay, yeah. Let's take Fatma. Your Fatma, Mike.
Yeah, okay. So,
I think, no, Fatma, if I may, I'll ask Ahmed to go, and yeah, because you are not completed case, while Ahmed is completed. Yeah. So Ahmed, can you go ahead, please? And can you unmute your mic, please? I know this is the first time you are using Zoom, so, but it's not different from our. Ahmed, are you able to unmute your mic? No?
Yeah, I'm able, but I'm trying to share it. I gave my permission to. I hope you can see the screen now, right?
Yeah. Yeah.
Yes.
Okay. Hello, everyone. Today, I'm going to present my case. It is non-surgical root canal retreatment of tooth number 15. The difficulty level here, according to the American Association of Endodontic for case difficulty assessment, it is moderate because it got 37 score, which is moderate from 21 to 40. My patient initials is LB. He's 25 years old. He is male from South Africa. His chief complaint was I went to a dentist in my country that time. I had pain, and she said, you need to retreat the tooth. Once she initiated the procedure, she said, I perforated the tooth and I advise you to visit a specialist. After that, I came to Dubai, and last week I had pain from the upper right side. And I think the infection was spread to all my body. I contacted my previous dentist, and she prescribed some antibiotics, and she advised me to visit the clinic. So uh, for his past medical history, it was all normal, but augmentin was prescribed one week ago, and he finished the course. Cataflam was also prescribed for the pain. For his dental history, no history of pain or discomfort except in the complaint tooth. He has history of root canal fillings and multiple teeth, and he had continuous pain last week of the tooth number 15, resolved at the appointment day. Without analgesic, patient had pain 4 out of 10 intensity, but with analgesic, it was 1 out of 10. Today, he described the pain, I mean the day of the appointment, it to be bearable without analgesic. Pain provoked with eating, according to his previous dentist, tooth is perforated. For the extraoral examination, no abnormality detected were detected. Intraoral examinations for the soft tissue, no abnormalities were detected, but for the hard tissue, tooth number 15 contained white temporary filling, which was GIC. For the periodontal condition, it was within normal limits. For the specific examination of the problem area, tooth number 15 was the chief complaint tooth. Teeth number 161424 was controlled teeth. As you can see here, it was negative to cold or APT, and it was positive to percussion. There was tenderness. No pain with palpation. According to Miller's classification, it was class 1, which is mobility classification, and he had pain on biting also. For the intraoral periapical radiograph of the upper right posterior teeth, as you can see here, the tooth number 15, there was a radio opaque material in the middle third of the root, which could be gutta-percha or calcium hydroxide, and radiolucency in the apical area. And this is the bite wing. Here we have normal bone level, and we assessed the restorability in this tooth, and it was restorable according to McDonald's index. For the diagnosis, the pulpal diagnosis was previously treated, and apical diagnosis was symptomatic apical periodontitis. The prognosis here was questionable. We had multiple treatment options. We chose non-surgical root canal retreatment, and alternatively, we could do surgical root canal retreatment. So it was considered. As you can see here, this is a periapical radiograph. Once we start the procedure after obtain the consent and administration of the anesthesia and access cavity with copious irrigation of sodium hypochlorite and saline, while we are trying to obtain the working length, we had suspicion that really the tooth is perforated. So CBCT requested to confirm the morphology of the roots. This is some screenshots of the CBCT. As we can see here, the tooth had different morphology and very rare morphology. In the tooth number 15, we have 3 roots with 3 canals. And as we can see, the problem, it's between also the buccal and the roots and the palatal roots. We had a very huge radiolucent lesion. Okay, we continued the treatment. Working length was obtained with electric apex locator and confirmed with radiograph. Cleaning and shaping done with K files and ProTaper Universal. Copious irrigation was done through the treatment. Non-setting calcium hydroxide placed in the canal, and patient was advised to wait 1 week till the next visit. This is the calcium hydroxide radiograph. And this is the master cone after we reopened the tooth and we irrigated with 2.5 sodium hypochlorite and EDTA 17% and activated with endo activator. After canal were dried, obturation done after obtaining the master apical cone done with warm vertical compaction. Cotton pellet placed on GIC and patient left without any incidents and referred to the prostate department. Here is our obturation. And as we can see here, this is the diagnostic and the working length and master apical cone with obturation radiographs all together with the preparation methods and my files which I used. For the literature review, according to the European Society of Endodontology position statements, and also according to the American Association of Endodontics position statement of CBCT using in endodontics, they all both agree that CBCT should be used and considered for the initial treatment of teeth or the retreatment of any case which suspected complex morphology. According to Vertucci et al., which is one of the most famous studies done in dentistry, Vertucci reported an incidence of 1% maxillary second premolars with 3 canals. And also, according to Picora et al., he reported an incidence of 0.3% of maxillary second premolars with 3 canals. And because our patient is South African, I found this study or the poster which done. We had here 285 patients. 4 of them had 3 canals in the second premolars or 3 rows. And the percent here is 1.4. And thank you.
Thank you, Ahmed, for the presentation. Professor Henry, if you like to lead with questions from your team.
Yes, I think the students may have some question first. So is there any question for the procedure or any opinion? Jihan, no question?
Have you faced such a case, any of the resident in Busan? Did you treat a premolar with rerouted?
Maybe some of them may have some cases with quite similar one. But half of them today, they are first grade of residents, so they don't have cases. But second grade, they have some cases with rerouted premolars. How about
Actually, there is one thing to highlight here, that this is a combined, this tooth has been previously treated. So one of the canal had gutaperca in it, Sah Ahmed? I think it was the mesobuccal.
Yeah.
Can you show the X-ray just so that's the initial.
The initial X-ray, it wasn't visible enough, as you can see here.
Mm-hmm.
Yeah.
Okay, no, I mean the CBCT then.
CBCT was, as you can see here.
This one here,
was in the mesobuccal canal.
So I have a simple question about the CBCT. So how many cases, percentage of your whole cases do you take the CBCT in your clinic?
It depends on the type of the case, Professor. If it's retreatment and I opened it and I found some difficulty in the morphology or missing MB2, especially in the upper first molar, we are aiming or obtaining, seeking for or requesting for the CBCT according to the guidelines and according to the position statements of the American Association. So it's not all the cases, but maybe if out of 10, maybe we can have 5 or 6 cases we can take because nothing, I think, forbidden for that.
Oh, you mean about 50%?
Yeah.
In not all the cases, yeah, not all. Especially if there is something weird or difficulty in the morphology, we are requesting. In some cases, like trauma cases, we are seeking for the CBCT also to assist the trauma cases. So it's depend on the case type and the situation of the case.
Yeah, sure. So totally agree that. But in Korea, so we are totally covered by the national insurance of the treatment. So the CBCT is quite prohibited from those insurance policies. So it's quite difficult to take that one. So maybe in our clinic, it's less than 10%, I think. So even we wanted to take the CBCT, we always have to think about that the government insurance, they can permit or not. That is our problem. So that's why I'm asking about that.
Yeah, actually, Henry, just to highlight this point, we have the same issue here with the insurance companies. Yeah, but there is a small catch, actually, which is funny. If you ask the insurance company for approvals, it might take time, and they will ask for co-payment, which is around $50 for because the patient has to pay part of the CBCT. But we are giving a special price for our residents. If they order the CBCT, the total cost will be $50 around that amount. So that's why we lower the cost, because we just taking the segmental CBCT, as you see here, 4x4, but it has to be ordered by the residents. And if it is a case where like in this one, for instance, justifiable because of the anatomy, we even somewhat cover that cost. That's why we kind of sorted that out, but I wouldn't say that as much as we like to, I mean, there is of course room for improvement, but I would go around 50%, if that answers to your question.
As Rashid told me, we still envy your condition. We cannot do that. We even cannot ask us just 10% about extra charge about the taking CBCT. All the procedures should be done under their guideline. So extra charge is totally illegal here in Korea. So
well, the thing is, because we have that kind of manipulation thing, because if the insurance company sometimes they disapprove that, we ask for patient can pay cash if he want. Any procedure can he do that? And because we give special prices to our residents, so that funny enough, I found out yesterday, for instance, that the cost of panoramic is here, if it's ordered by our resident, is the same cost as the CBCT. The finance department did that. So why should I order a panoramic if I have to cost-wise, But again, it's I understand that each country have their own limitation, and if we were based only on the approvals of insurance companies, I wouldn't say we would have more than 10%, like you.
Okay, thank you. Dr. Acharpilan, sorry, I cannot exactly pronounce your name. Dr.
Ahmed.
Yeah. So I found that in your presentation, you used the ProTape Universal.
Yes.
Not the Universal Code, classic ProTape Universal.
Yeah, I used that one.
Oh, I think ProTape Universal is quite a stiffer instrument than the recent instruments. So do you have any other option in your clinic?
Yeah, of course, we have ProTaper Next. We have also the Gold, ProTaper Universal Gold. And we have Wave 1 Gold, we have iRace, we have most of the files we are using.
Then I have to ask that why you select that the instrument ProTape Universal?
Because I was able to use it that time. It was it gave me a good shape in the preparation after that, and the taperness in that the taperness will be help me in the preparation, because the canal was a little bit wider than usual. So if I used the ProTaper for example, I could go with larger file. That's why I chose the ProTaper Universal.
Okay, great. So also I found that you have the temporary restoration with Grace Normal. So do you use the Grace cement? Every case is for temporary sealing?
Yeah, it depends on which visit I will use the temporary restoration. If it's in between visits, and between if I use if I will see the patient next week, I will put cavit as a temporary filling. But after that, once I finish the case, I prefer to use GIC as a temporary filling, because it's better in isolation, especially after obturation, and better as it and it will withstand any mastication force better than the the cavit, and also it's against the bleeding. It can sit with the bleeding, especially bleeding from the clamps, and it will give patient time until he visits the prosthodontist or any general practitioner to put the final restoration.
Okay, that is a good idea. So we actually use the cavity-like material between the treatment appointment, but when we need to wait quite a long time for the next appointment, we sometimes put the Grace cement as like you've done. So that is a good idea when we choose the materials. Okay, great. Any other comments from the third floor here, Busan? Second floor, sorry. No question? Yenny?
Okay. I guess it's your turn now. Your resident turn.
Yenny, no
can you stop sharing, Ahmad, please?
Okay, then we can present another second one. Dr. Kang, are you ready?
Hello, this is Sujong Kang, and let me start our case discussion. This case of female age 32 has been referred from local dental clinic. As chief complaint, she came here for fistula on left maxillary central incisor. Chief complaint site is number 11, 21, and 22. She didn't have any past medical history, but she had past dental history, which is root canal treatment and crown on number 11, 21, 22, 2 years ago at local dental clinic. This is the panorama on the first visit. We have found none of pain, percussion, or mobility, but we have found that upper part gingiva of number 21 has fistula. Looking at the radiography, we found root canal filling and post on number 11, 21, and 22. This is combined computed tomographic image. Looking at this site, you can find loss of buccal bone. Looking at this slide, you can find periapical lesions here and here. And I had two different options for treatment plan: root canal retreatment and apicoectomy. Putting non-surgical root canal treatment as our first priority, I thought root canal retreatment. but her crown has been only 2 years and she also had post-planted. So I thought orthograde root canal treatment would be difficult. So apicoectomy was another option. I want to discuss about those 2 treatment plans. Thank you.
So here now we are all 20, right? 20 or more. So we can vote now. I prefer surgery.
I'm sure Muhammad will go for surgery. MJ, our boss, it's his kind of team. Anything to say, Muhammad, about that?
No, Rashid. I think I will leave it to you guys. But before I leave, Rashid, you know that I need to go for another event.
Course,
so I just want to thank Prof. Henry for such kind of collaboration. And I want to thank Rashid for arranging this. It's an excellent start, and inshallah, it will continue. I do apologize. I need to go for another meeting just now.
But
so
one last
thank
thing,
you, guys.
then. Where your vote will go, Muhammad? Surgery?
Yes.
Okay. So you can go.
Yes.
We got your vote.
Thank you. See you next
Bye-bye.
time.
Have a good one.
Bye-bye. Bye-bye.
And do we have any clinical photographs?
Oh, Professor Kivan, sorry, I didn't see. Professor Henry, allow me to introduce Professor Kivan. He is also part of our team. Kivan, I think if you a couple of words to introduce yourself, we all did, if you don't mind.
Yes, please.
Thank you, Dr. Rashid. And it's very nice to meet everyone, Professor Henry and the team. I'm Kayvan Muharramzadeh. I'm a professor of endodontics and I'm the Associate Dean for Education at Hamdan bin Muhammad College of Dental Medicine. I've joined MBRU in September last year. So it's been over 1 year. And previously I was based in the UK in University of Sheffield. So it's great to see this joint case-based discussion session. I've really enjoyed the presentations. Thank you so much, both sides, for organizing this. It's really nice, and I really enjoy seeing these collaborative efforts. So yes, thank you. Dr. Rashid, and many thanks for the presentations, colleagues. So yes, with regard to this case, to decide whether to go for surgery or a non-surgical approach, I would like to see some clinical photographs. Especially the reason is to assess the aesthetic parameters, the gingival condition, and also the crowns themselves. So if the crowns are, very good and the aesthetics is very good and the soft tissue is very favorable, then it's driving me more towards deciding about surgical treatment to avoid sacrificing the crowns and also basically, removing all the posts, which are going to be challenging. I believe these are all fiber posts in the canals. And if we have multiple lesions, especially the lesions are large or connected to each other, then they can be inoculated and cleaned surgically. But then if the restorations or the crowns are, for example, impinging the biological width and there is need for crown lengthening surgery as well, or there is additional pathology, then also it would encourage deciding about surgical treatment as well. So that was my comment.
Nice comments about that. Is we have to think about the Crohn's condition and gingival condition. That is very exact point. So, Dr. Kang, you didn't show us the tracing X-ray. So, don't you have that one?
Oh,
you told us what is the origin of that fistula, the 21?
Yes.
Yes. even the fistula is originated from only one tooth from those three root canal treated teeth, but all the three teeth has the apical lesion. So even we have the retreatment non-surgical approach, maybe the other two teeth may have some problem in the near future. So that is also we should consider. So my opinion, the personal opinion, is to do the surgical approach to for the all three teeth once you make the surgical approach, not only for that tooth one, but for all three teeth. That is my simple idea. How do you think about that, or from the MBRU, about my idea? Yeah.
Going to do an surgery for the all three. So are you going to extend the osteotomy like from the canine to the central, or are you doing only each osteotomy? It's like different, like a specific osteotomy for two, specific osteotomy for one, and etc.
Osteotomy, you mean? So once maybe Dr. Kong, if you make the flap reflection, the flap is of course one flap, big flap, and then she may go for the three osteotomy for each one root apices, not the whole big one, maybe. Dr. Foster, you asked about that, right?
Can you show the CBCT again, please? Because I guess there is one of the root already, the bone is exposed, right?
Yes, yes.
Yeah, this one. I mean, the next CBCT too, yeah. So you already have root resorption of the buccal bone in the central in 2-1, I think, right? If you go to the previous slide. Previous one, the
next slide. Yeah, this one.
This one, yeah. So here, yeah, I guess I agree. It would be separate osteotomies, Fatma, if it's going to be my surgery.
So in Korea, we are not the Department of Endodontics. We are actually conservative dentistry. So we have a duty to preserve the bone tissue also.
Okay. I would have to say, just for the sake of time, Fatma will have a presentation. I think it's around 7 minutes. Do you have time to sit with us for Fatma's, or you have to go, guys? I'm not sure. Henry.
Oh, yeah, it's okay. So let's go for a short moment, briefly.
Okay. So, yeah. So let's go for Fatma's.
Reception.
Actually, this case, it's not that it has not been completed, but because you will see a bit of an issue that we don't know what to expect. So I guess it will be clear why we are presenting this case, because we wanted your opinion also on that. Do you think that our approach is fair, and would you suggest anything else? So
Yeah,
Fatma,
that is our purpose to have the joint seminar. Good.
It's a case for resorption. It's a patient which is 17 years old. The difficulty assessment was like moderate. So the chief complaint was only something is bothering in an upper left tooth with a small pimple. So he is a medically fit, a dental history. Patient was completed his orthodontic treatment just recently with a history of impacted canine, and which the exposure was done 2017. So it was everything normal except when he came to his regular orthodontic follow-up. So they noticed sinus tract, and the patient was complaining of discomfort. So they referred the patient to us. So extraoral and intraoral examination was within normal and except the sinus tract, which is observed in the tooth between 2.2 and 2.3. So for the cold test, the tooth 2.2 was negative and tender to percussion. So this is the tracing radiograph. As we can see, there is an external resorption for the tooth 2.2 with the big radiolucency. And this is the previous radiograph that where the canine were impacted. Then this is exposure, and this is the final orthodontic treatment. So the patient was referred to us and taking, and again, we take a CBCT because it's a recommendation to use a CBCT for a resorption case. So we can see that extent of the resorption and the radiolucency was here irregular. As we can see, it is more on the distal part of the root, and the extension was perforating also the buccal plate. So here was our first diagnosis was pulpal necrosis with a chronic apical abscess, and the pathological phenomenon was external inflammatory resorption, which can be sterile in our condition, which is due to pressure from orthodontic treatment or impacted canine. So the treatment option was do nothing, a non-surgical root canal treatment with long-term calcium hydroxide dressing, and the RCT with a surgical endodontic. So our first option was to do the non-setting long-term calcium hydroxide dressing. So this is our dressing, and this is after almost 6 months of long-term calcium hydroxide.
Sorry, Fatma, just be a bit slower. I think we missed some of the slides. You have 2 minutes more, okay? So just show us the X-ray. You started the treatment with non-surgical in 10th of August 2020, right?
12th of August 2020, yes.
12th of August, okay. And
calcium dressing
hydroxide dressing, okay.
Was placed there for 6 months, almost August. This is on October, then in December, and okay. After that, on February, after 6 months, almost 6 months, and we find somehow there is like a bridge in the apical part, so we decided to do the filling. So because of the resolution and also of the sign and symptoms, there's no sinus tract, and there is like seems that the periapical radiolucency was reduced in size. So we did.
And you use 2 layers, MTA.
For apical plug, then we do the GP.
Okay.
So for the follow-up, after 2 months, the sinus tract was closed. After 5-month follow-up, it's reappeared again. So this is the radiograph that we did tracing after the filling of after 5 months. So in this area, we did take a new CBCT just to compare the volume and the size of the lesion. So this is what we use a different software to assess the pathology and the tooth volume. As we can see here, that preoperatively in 6 months and after 1 year, we can see the pathology here was like there, and then it was decreased after 6 months. Then unfortunately, it was increased again. So the tooth volume here, we can see it was decreasing all over the time. So here we, this is the extension or direction of the lesion. We can see there is the lesion which can went to another like different direction, which is as we can see here, it is more coronally and distally. So here we decided to go with the second option, which is the surgical option, just to remove the resorbative defect, because we don't want to go with extraction and then the patient is very young. So we want to preserve the tooth as much as we can. So this is a planning for the surgery. We did the 3D reconstruction for the planning and training. We did do the 3D printing of the case, and we planned and trained before the surgery itself. So this is the surgery day. We can see that already when we did the flap, there is also a buccal, a dehiscence in bone. So we removed the granulation tissue and we try to clean and expose the root. As we can see here, the aim of this surgery was not to cut the root itself, but was to remove the resorptive defect and to enhance or give the tooth more better environment for healing. So we did remove. This is, as you can see, this is a resorptive defect, and this is an MTA. So we tried to remove the resorptive part, and we use a ferric sulfate, of course, for the hemostasis and the areas. So
your voice is a bit low. I mean, I'm not sure about the mic or something. It's cutting a bit.
Okay.
And you can go to the end of the surgery. It's okay. Since
so almost the end of the surgery, as we can see, it is clear that we remove all the resorptive defect, and then finally placing a membrane with the help of our periodontist, and then suturing. So this is a follow-up which the patient was present yesterday in our clinic for follow-up appointment. The patient was presented asymptomatic. There is no sinus tract. The tooth was free of any symptoms. There is no tender tip percussion or any mobility in the tooth. So we take a new PA, and it shows somehow there is an reducing in the size of the radiolucency. But we hope so to follow more and see what will go on. And thank you.
Interesting.
Thank you very much, Fatma.
Thank you for interesting cases. So is there any question or comments from the Busan? From the resident group? Me? No question?
Actually, I have a question for you. If it was your case, Henry, what would you have done? Would you done anything differently?
Actually, have some question about these cases. Do you think what is the reason for the recurrence after the long time calcium hydroxide application, and then you have done the non-surgical procedure but recurred? What is the reason, do you think?
I think because of the irregularities that in the apical area, maybe that we couldn't reach and the wall of the roots and calcium hydroxide to have an effect, it should contact all the areas. I think it was somehow irregular resorptive that it's going on. This is a reason for.
So if I have that cases here for my patient, I would have done with multiple change of calcium hydroxide, not instead of the long application. You have the put the calcium hydroxide for 6 months, but I may replace the every 1 month or 2 months.
We did that actually. We did like every 2
did that.
weeks a month.
Oh, really?
Yeah, the calcium for 6 months almost.
Mm-hmm.
Not for 6 months.
Okay, so it's quite a complicated situation to have that kind of recurrence, but you did good surgical procedure. So after the surgical root and approach, you didn't put the new MTA, right?
No. Because we do any the apical preparation. I mean, apical end preparation.
Yeah, actually, I know you have already put the apical plug from the non-surgical approach, but the apical plugging does not make the perfect sealing at the apical with the apical canal. So if I do the surgical procedure again, I may try to remake the apical preparation cavity and then re-put the MTA from the apical side. That is my idea, because we have to make you don't want to make another recurrence. So that's my idea.
But we don't want to that the idea was only just not to compromise the root more than what we did. So we just
yeah, sure. That is also a good idea.
Anyway, we are keeping our finger crossed that it's 3 months, no sinus tract. But again, no one knows, because if I had a clear idea, a clear vision why there was a relapse and the causes for reoccurrences, I would know for sure that I have eliminated this relapse reasons.
Mm-hmm.
So we hope that the surgical approach will resolve this, but again, we don't know. We hope the next meeting, hopefully, we will be able to show you even, this patient came just yesterday, that X-ray was taken yesterday, but do we guarantee anything? We don't. And that's why we wanted to share and get your opinion, if it was your case.
Rashid, actually, I have one more question about those procedures. So that Fatma put the membrane from the parental guys, but in our department, we are not commonly use the membrane. So did you put the bone graft or membrane together, or just membrane?
We didn't put bone graft because we don't want the bone graft to mask our healing process, because the opacity of the bone itself, it can mask the healing. So we don't know what it goes healing or not. But we took an advice from our periodontist in our department. So they advised to use a membrane just to help with the area for a better healing. That's it.
Totally agree.
And usually when a membrane is placed, it's the perio department who comes and assists us with that at that stage.
Totally agree that you didn't use the bone graft materials. I don't use the bone graft. But for about membrane material itself is a artificial one, so it should be reserved inside of our body. So it takes time, and also it's a kind of low level of long-term inflammatory procedure. So that's why I'm not using the membrane neither. So that is my personal idea. So I don't put my push my students to not use that, but they just part of my philosophy. What do you think about that, Rashid? About the membrane?
I totally agree with you, Henry. I wouldn't say a membrane, and I hope if next time we'll be showing our surgical cases, is something of a common practice. But her case, because of all the complexity that happens and even the patient age and so on, we had that discussion with the periodontist. But if you look at our standard episectomies and other, you wouldn't see that as a routine. Actually, we even have some difficulties in the billing because membranes are separate bill from the endodontic surgical procedure. But I guess because of the complexity of this case and the periodontist advised us to go ahead. But is it on a routine practice of our surgical endodontics? No, it's not. I agree totally with you.
Okay. Anyway, it is very nice cases. The good approach of non-surgical way, and then unfortunately she got the recurrence, and then she actually done the good surgical procedures. So it's very nice cases. I hope to see these cases after 2 to 3 months, like next time, with good result.
Hopefully, inshallah. Right, let's take one more picture, guys. So if you can open your cameras at the end of this great meeting.
Yes, it's very nice meeting. So hope to see you again next year, maybe January, February, something like that. So
yeah, it would be.
yeah, with another good cases. Thank you very much for joining this time. And then we may take the screenshot with shaking our hands. Like
yeah.
this.
Okay.
I will take one.
Yeah, okay.
Very
Can
nice
you take
to see
one?
you. Yeah.
Bye.
Good. I will send you the screenshots.
Yeah, I'll wait for that, bro.
Yeah.
Thank you very much.
Thank you very much. Have a nice day.
Thank you. Thank you very much. Bye.
Bye.
Thank you very much.
Thank you.
Thank you very much.